Good morning. My name is Alice Scanlon, and it is June 21st, 2021. I'm the educator for surgical services at Baptist Health-Louisville, and over the years I have discovered that new to the OR nurses have trouble figuring out how to position an OR table for certain cases. So what I did was scale an OR table down to the proportions of a 12-inch fashion doll, which is 1 to 6 scale, and that math is, if you multiply all the different measurements of an OR table times 0.17, you get the measurements that I came up with. I bought a 1/2-inch board at the hardware store, and a friend cut out the pieces that I asked him to cut out in the shape of an OR table. So I've got it as close as I could get to the actual scale of an OR table. When you bring a patient into the room, you want the head as close to the patient's head as close to the head of the table as you can get, so anesthesia will have access to their airway. Sometimes, though, if you have a vaginal procedure, it's easier if you can scoot the table down. So before you put the patient on the table, you would have the head at the foot, like so, and that way her head can still be at the top of the table for anesthesia, and you don't have to pull her down quite so much to get her buttocks to the cutout of the table, which is what you want. When you put a patient up in stirrups, you want to make sure that the stirrups are on the stationary part of the table. I'm going to take this part off. We can take that part off as we would in real life. Oops. The stirrups need to be on the stationary part of the table and not the part that drops. And that, you can do that. You can make that mistake. So it could be dangerous if you put the patient's legs down and the stirrup is on the movable part of the table. So you got to teach them to put it on the stationary part of the table. So another thing that they can mess up is you've got the head at the foot like you want it, but if you don't have the pads in the correct position, I've seen this happen before. You get your patient down, and you don't realize, because this is all covered with sheets, and you go to put the bottom down, and you've got this table pad in reality is 4 inches thick, and so you could not utilize the cutout of the table to put a vaginal speculum down there. So you want to not do that. Let's see. Sometimes I'm going to put it back in the routine position. This is the OR table in a routine position. Sometimes you need to do a cysto case to put stents in up the ureters before you do a big belly procedure, so the surgeon can make sure he's not cutting the ureters. To do the cysto, you have to bring the patient all the way down here, and then the stirrups would be down here, but you're not going to drop that part. But you would bring the patient all the way down here, so you can get a C-arm around their flank, so you can see the stent placement. Sometimes you have to put the head at the foot and turn the table for a gallbladder surgery. So you would put the head at the foot. It always starts out in the routine position, and you go from there. So put the head at the foot and turn the table. This is anesthesia up here. Then I would turn the pad around so they're not sitting in the hole. This way, my table falls apart a little bit. You can bring the C-arm in to x-ray this area of the patient where the common duct is. They do that during lap gallbladders a lot. Let's turn it back to the routine position and put the pads back where they belong. And maybe we're going to do a nephrectomy. So we're going to turn the patient, bottom leg bent, top leg straight. Bring the arms out. We're going to put a axe roll in there to prevent nerve damage to the down arm. And right here is a space where the kidney rest would be pumped up. And you would want the flank right over. You'd move her down until you get the flank right over that kidney rest. You pump the kidney rest up. Of course, it doesn't work very well on this table. And you get her in a position to where that you've got a good exposure on that kidney.